Thank you, and good afternoon, everybody. It's very good to be here at the first virtual NPA conference, and this is the second day. This is quite obviously an experiment, so I know that the team would be very grateful for any feedback that you want to give at the end of this. Just to introduce myself, I'm Jackie Doyle-Price. I'm the Member of Parliament for Thurrock. I'm a former Minister in the Department of Health. And I'm here really in my capacity as chairman of the all-party group on pharmacy, where I want to do my best to respond to the views of you in the sector and to champion it with the Department of Health. And, you know, I'm actually very pleased with what we've done so far. I know yesterday you had the first appearance by the Secretary of State for Health in 25 years. And it's worthwhile just reminding everyone of some of the messages that Matt Hancock made yesterday, because there were ones that I think the sector will be very pleased to have heard. He said that he wants NHS pharmacies to play an even more active role in clinical services, very much recognising the role that pharmacy can play in delivering primary care. He fully appreciates the nature of community pharmacy and the way that they're embedded in the communities, and I think that obviously has become really writ large during the corona crisis. He also said he wants to recognise the role that pharmacies can play in vaccination, which again is very, very welcome. And I think probably the most important thing he said, given previous debates, was that the suggestion that we had too many pharmacies and the sector was inefficient ended the day he walked through the door. So I know that for many of you, there's lots of concern about resources, but I think as an opening gambit in a conversation, that's a pretty good start for the sector in terms of where we've been before. So I will look forward to supporting further dialogue between you all and the Secretary of State. But in terms of today's session, we are here to consider what we learned about community pharmacy during COVID-19. And I'm very pleased to have a fantastic panel to give us their views on this. I should say at the start, if you want to contribute questions, because there will be opportunity for questions at the end of the presentations, if you could not use the chat button or raise your hand, but use the Q&A button, and then we will collate them and put questions at the end of the presentations. So you've had enough of hearing from me. I'd now like to introduce Jason Leach. Jason, you've probably seen on TV, is the National Clinical Director for the Scottish Government. We thought it very interesting to get a perspective on community pharmacy from a senior healthcare professional who is not a pharmacist. And I'd also just like to make the point that I've always believed we can, although we now have devolution, and that's great for regional initiative and innovation, but we must also have that dialogue between the four nations so that we can learn from best practice. So in that spirit, I would like to invite Jason to speak to us.
Jackie, thank you I don't always get a bell ringing when I come online, but I'd like that every time. Hello, everybody. Thank you for having me. It's a great privilege to be here. I'm sorry I don't have more time. So we've got about 25 minutes to do a little bit of stimulation, perhaps, and then take some questions if you've got them before we lead into the other speakers. So the first thing I should probably say is I'm sorry I'm not a pharmacist. I'm not that sorry I'm not a pharmacist. I mean, I'm sorry that I don't understand your context as much as you do. I do understand a little of it. I've spent quite a lot of time with colleagues and friends now across the country, particularly during this period with the community pharmacy associations, with actual community pharmacists, and the Chief Pharmaceutical Officer in Scotland, Rosemary Parr, has the office directly across the corridor from me in non-COVID times, and our paths have crossed a lot, and we speak every day on our broad directors call to try and run the Scottish Health Service. So I'm not going to do a pharmacy focused 10 minutes. I'm going to try and do a slightly broader version of where I think we all are, and then with a little pharmacy story as we go along, perhaps. But others can, of course, add more pharmacy colour than I can. So let me just share my screen if this will work. So this is the grass market in Edinburgh. Many of you will have been here. It's just down from the castle. The castle is just behind it, in fact. It's a big steep hill up to the Royal Mile, and probably the busiest square mile of Scotland. This whole row is pubs and restaurants, and all the way up the hill, more pubs and restaurants as you climb back up to the Royal Mile, a few tartan shops to sell you a haggis or a kilt on your way up. This is 3 o'clock in the afternoon on the 24th of March. We basically shut down society. We've never done this before. We've not done this in living memory. And it's the single image to me that illustrates the nature of what we have faced and the response we have had to do. We're not messing around here. This is an actual global pandemic, and I will illustrate that with some data in just a moment or two. This place is busy at 4 in the morning, not just at 3 in the afternoon. And this is 3 in the afternoon. We've kept people in their houses for 4 months. And you can't do that without cost, of course. What we haven't done is, despite what you might read in the paper, is shut down the health service. We've kept large sections of the health service working, and in fact, many sections working harder and faster than they've ever worked in living memory, including much of pharmacy. Pharmacy in its broadest sense, from the GP practice pharmacy in Barra with a few hundred people and one medical professional and one pharmacist covering that tiny island, to massive community pharmacies and chains in our big urban centres around the 4 countries. It's important to realise, though, what we have done to society, and we've done it because of this. This is Scotland's data. The 4 UK countries' data curve looks very similar. There's slight variation in the peak days and a couple of weeks here or there. But roughly speaking, this is what the UK curve looks like. Everybody peaked in April. The dotted line is the 7-day moving average for new cases. It just flattens out the spikes. And we're now in Scotland down to single figures a day. We had 3 positive cases today. Is it 12:30? Yes, I can now tell you that we had 3 positive cases today in the last 24 hours, which is consistently below 20 for the last 2 weeks. We had 18 or 19 over the weekend, which worried us a little. England had 860 on Friday, the highest single total since the 22nd of June, 6 days after you opened indoor hospitality. I can't draw a direct line between that and indoor hospitality, but most of us in this game would think that's not a coincidence. You can't keep it closed forever. You can't, the lockdown has costs for businesses, for society, for mental health, for other diseases. That takes us to hospital admissions, running with a very, very similar curve, but slightly more compressed, a slightly higher mountain. And this is our Scotland's hospital admissions, now down to almost 0. And this, unfortunately, is deaths. The top line, the dotted line, is our 5-year average of all deaths registered per week in the last 5 years. And the blue line is the 2020 figure. So all of that curve is COVID death. That's everybody registered as dead with either a positive test for COVID or suspected COVID on their death certificate. Now, the 3rd week in June, which this data takes us up to, back to normal death rates. So about 1,000 a week in Scotland and down to about 35 registered COVID deaths. In fact, last week it was 19 and continuing to fall. So there are no excess deaths to COVID with our present situation. Let me put this global pandemic in perspective for you in case you've misunderstood it. And you could be forgiven for misunderstanding it, depending on which media or which commentators you listen to. The WHO has a thing called a global public health emergency. They have a category and they announce global public health emergencies to the world. So they tell the 194 countries to be careful, there is now a global public health emergency. They consider 300 of these every month, and it's a very, very high bar to get classed as a global public health emergency, because they want the public health community in each country to pay attention, to do things, to have a response. And these are just an example of the big ones. These are the 7 large public health emergencies in the last 20 years. And to put them in perspective, you may have heard of the Zika virus, a particular challenge for pregnant women, particularly in Latin America. And we had a global response. We had COBRA meetings. We had the equivalent of COBRA meetings in the 4 countries. We mobilized the health service to deal with Zika. You'll remember there was quite a lot of publicity, quite a lot of media coverage of Zika in 2016. It infected 175,000 people and killed 18 globally. The Middle East Respiratory Syndrome, which is the one that everybody says we should have paid more attention to, that's in 2012, not in 2102. I need to fix that slide. It's not a future pandemic, fortunately. So that Middle East Respiratory Syndrome virus, which has got quite a lot of similarities genetically to the SARS virus we're now dealing with, infected 2,500 people globally and killed 866 of them. 2,500 people. We got nothing but a few imported cases. So let's go to 2019. End of 2019 in China, beginning of 2020 in Western Europe and the rest of Southeast Asia. This present virus has infected at least 12.5 million people with positive cases, positive test results for PCR testing. We think probably it's 100 million because there's no testing in sub-Saharan Africa. There's no testing in Syria. There's no testing in Yemen. A whole lot of the Middle East is a complete mystery to the data. And it has killed at least 560,000 people. On Friday, the WHO announced they had the biggest single day of COVID-19 infection since the pandemic began. 230,000 people tested positive for COVID last Friday, mainly in Latin America and Southeast Asia. Latin America is completely out of control. If you watched the WHO press conference yesterday, you'd be completely terrified. Mike Ryan, who's the head of emergencies, who's an Irishman, and doesn't mince his words, looked absolutely exhausted, completely exhausted. This is like nothing the world has ever faced. Just because the pubs are open and the gyms are open doesn't mean this isn't a massive public health challenge. And I'm not trying to scare you. I'm just trying to keep it in perspective. The Spanish flu epidemic of 1919, just after the First World War, was of this scale, but the world didn't look like it looks. It wasn't as densely populated. We didn't have megacities. We didn't have all of the things we now have. This is the greatest public health crisis in history. So where does that leave us in the UK, and how do we respond? Well, I think the 4 countries have stepped up and responded remarkably well. We've lost 40,000 people to this virus in Scotland and many more across the 4 countries. We have unfortunately lost many in our care homes and our vulnerable in particular, but the health service has transformed. Pharmacy, dentistry, optometry, acute care, everything has changed the way it does business. And this has been the broader mission, because you can't just think of this as a COVID-19 crisis. It's a population crisis of non-virus harms as well. So if you can't visit your family with dementia in a care home, that is a health challenge. That's not just a society and a kind of ethereal challenge for your family. It means the elderly relative will probably fall over more. They will probably be more confused. They may well die sooner, because visiting is a health intervention, not just a person-centered intervention. So we have to do that while keeping the health and social care system protected. So I've done this a little bit at the beginning, but I have been nothing but impressed by the health and social care teams stepping up in this pandemic and changing the way they do work, changing the way they access and use PPE, changing the way they do. So a tiny example of my parents are 79. My mum has quite bad COPD. She's not shielding, but she's in quite a vulnerable group. They live about 50 miles from me. My sister looks after them a little bit, but they're perfectly independent and capable. But their local pharmacy reached out to them to make sure they had the drugs and medicines they needed. They didn't like bothering people, my mum and dad, so they're relatively traditional. But the local pharmacy where they get the prescriptions reached out and said, look, how can we help you? Right at the beginning of this, at the end of March, they said, what do you need? When do you need it? We will come to you. So through no initiative of my parents, the pharmacy connection was made. They've been very impressed. The GP and the primary care system all joined up and working beautifully. And not because I was the national clinical director. They didn't know that these were my parents. They do now know because they've had a lovely thank you letter from the national clinical director for doing that. It's just a tiny example of how important pharmacy has been. I asked once in this job many, many months ago, I asked, how many people are engaged with the National Health Service on a daily basis? And when we added up the numbers, it was half of the population of Scotland. 2.5 million people were engaged with the health service every day. And the vast majority of them were engaged in some way with pharmacy, with repeat prescriptions, with going for advice, with just buying over-the-counter meds. In some way, they were engaged with the National Health Service. Just about half the population on a daily basis. This is my kind of radical reform, and it doesn't feel that radical now, but this is Scotland's NHS Near Me programme. And it's about, in summary, it's video conferencing for appointments. But it was started by a pharmacist, and a young pharmacist called Claire Morrison, who did our Scottish Quality Improvement Fellowship that we've now run for about 900 clinicians across our country. She's from NHS Highland, quite far north, and they started with Pharmacy Anywhere. They started to take video conference into pharmacies. And now that has spread to outpatient clinics, GP practices, and now every GP practice in the country has video conferencing appointments available. They've gone from 300 appointments a week to 17,000 appointments a week being done by this. Not only started by a pharmacist, but started in pharmacy. So the work was piloted and prototyped inside pharmacies across the country and is now much more broadly used around the country. It's just a tiny example. There are many, many more. And I'll just finish with a little story of why I think this works so well. So we did some publicity, and I did a mock NHS Near Me appointment, and we were filming it for the BBC, and we were chatting. So I went into the waiting room, and you get to speak to a live receptionist. It's one of the things we did with the system. When we asked patients what they wanted, they said, well, we want to speak to somebody. We don't want to just see the little spinning circle where we're worried if anybody's there. So you speak to a receptionist, and she said, okay, we'll just put you in the waiting room, and the gastroenterologist will be with you shortly. So I then went through to speak to the gastroenterologist, who was live in Inverness, and I was in Glasgow. So far, so good. And we started to chat about his experience of NHS Near Me, because he'd been a bit of a skeptic and hadn't really liked the idea. And then he told me a story of the postman from Golspie. Golspie is on the far north coast of Scotland. It's very isolated, tiny village, nobody there. And the postman is a very important community asset. If you take him out for 2 days to go to a hospital appointment, stay overnight, come back, it's not good for him, for his family, or for society. So he'd had a colonoscopy, which he'd had to do live, of course, in Inverness. But his review appointment, his results were being given across the video conferencing. And he had called from inside his van. So on his iPhone, in the middle of his mail round, he'd taken 15 minutes to attend his hospital appointment, to meet his consultant and get his results. And the results were good, and he was told all was well, and he lit up a cigarette in the van. So he started to smoke in the post office van, and my pal, who's the consultant, he said, "Are you smoking?" And the postman said, oh, stubbed out his cigarette, threw it out the van, and he said, "I forgot I was at the doctor." It just illustrates perfectly for me, and I'm not condoning the smoking or thinking that's not a public health challenge, but it illustrates for me the difference between embedding healthcare in people's lives rather than making people travel to us to make healthcare some kind of special event for people and making it all about our convenience rather than them. So that's my pharmacy story, and I hope it encourages you to keep that innovation edge to your work. And I'm very happy to take any questions. Let me just stop sharing. There we go.
Well, thank you for that. You were billed as being someone who spoke clearly and directly, and I think you set out very clearly what the challenge is for us there. So thank you very much for that. Just coming then to some questions. The first question I've got here is, are you certain that the whole, well, more than 500,000 deaths are due to COVID, as distinct from people who died with COVID who may have died anyway? And I guess connected to that is, to what extent these are actually driven by COVID, and to what extent it's shortened lives that were already limited in any case?
Yeah, so I don't think we do know that yet. We will know eventually, and all of the public health leaders in the world think in the end the data that will become the most interesting is age-adjusted all-cause mortality. So age-adjusted all-cause mortality will become the single biggest data point, and that will show excess deaths during a pandemic. If anything, COVID has reduced deaths from other causes. That seems a bit upside down, but there's pretty much no flu in Australia, and Australia should have had flu for 2 months. So when it all plays out, we will be left with a curve, I think, that looks like that curve I just showed you. I don't know. It may have a second peak, but just now, everything under that curve at some level is being caused by something special, and the something special is COVID. Now, data is better in France than it is in Yemen, so we won't always know what's happened. In fact, some countries like Iran, you simply don't even know how many people die. So only over time will we know what that curve looks like. But in developed countries, Euro, it's an odd name, EuroMOMO, M-O-M-O, is the public health observatory across Europe that holds excess death data and a whole lot of other data for all kinds of purposes, and it will be the place that eventually tells us how many people have died from this disease. Most people think that in the end, Western Europe will look very similar. We will have had a different path in and a different path out, but in the end, we will probably look quite similar.
Right. Well, thank you for that. You very helpfully highlighted the growth in teleconferencing with doctors and pharmacists, and the fact that that was innovated within pharmacy. What more do you think the pharmacy sector can do to really highlight the very good practice that does happen in community pharmacies?
That's a good question. I think one you can answer yourselves better than I can. My instinct is to run towards the limelight with, I don't mean personally, although some would argue I do that. I mean to run as a profession towards the limelight and seek opportunity to engage. So I'm a dentist, and then became an oral surgeon for many years. I mean, I still get accused of being just the dentist when I'm at the podium with the First Minister giving public health advice to the community. Now, I would argue I've spent quite a lot of time on this game, and I'm legitimately standing at that podium. So I think you should run towards contribution. So people will not come looking for you. And if you sit back and complain that community pharmacy isn't involved, then good luck to you. That is not how to get engaged. The way to get engaged is to run towards it and say, look, we can help you with that. We will do that. We have answers to that. We have prototypes for that. So if you stay back, I'm not suggesting pharmacy do this. Dentistry is probably more guilty of this than pharmacy. Nobody loves me. Nobody includes me in the big boys game. I don't get invited to the big tables. Well, okay, you're not exactly inviting yourself. And you're so pessimistic and discouraged that I'm not going to invite you because it's not going to be fun. So dentistry is a bit like that. Pharmacy, maybe not quite so much. I think the prominence of the Chief Pharmaceutical Officer in Scotland is crucial. She is very, very engaged at a very senior level with the ministers and with the stakeholders. And I think that helps. So I think you have to run towards contribution, if that makes sense.
It does, because you can't expect anyone else to do your PR for you. You have to shout
Correct.
that yourself. I know we're all very modest folk, but you know that at times we have to be a bit more vocal about things. It also occurs to me actually that probably our best ambassadors are the users of our services,
Yep.
the public. I mean, when you think about the amount of contact that individuals have with their local pharmacist, you know, they are exactly the ones, and perhaps we need to do better to explain to them just how much you can get from your pharmacy.
And at one level, it's just including community pharmacy in the big list of contributing services. So we talk about ICU a lot, we talk about wards, we talk about care homes, but I try when I'm speaking out loud to say, first port of call, use your community pharmacy. But we need community pharmacy to come in behind that and say, and not say, hold on a minute, we're a bit busy, don't send me any more people. No, we're part of a primary care team, we're part of a community effort to engage around health service. Of course, you should also have a parallel track that says we need resourcing, we need the right PPE, we need the right people, we want the universities to do this, this, and this, of course. But if you're not the enthusiastic advocates for community pharmacy and everything that it can do for society, then nobody else is going to do that for you.
Spot on. So this is the challenge, isn't it? Is that the challenge of, you know, this crisis has forced pharmacy to step up to the plate. That's been brought with it its resourcing challenges.
Of course.
But equally, if we are going to have this future in the brave new world and do more and be a more respected and integral part of primary care, then we've got to run towards the fight as well as fighting for more resource.
And that's not your fault. So that can be hard in a CCG in England or a health board in Scotland to in amongst a load of voices crying out, organised royal colleges, the BMA, the Royal College of Nursing. I don't underestimate that challenge. I'm not suggesting that it's anybody's fault, but I don't know any other way of doing it other than pharmacy, community pharmacy, offering to be the part of the solution rather than waiting to be asked.
I agree. Now, I know you've got to leave us very shortly. Before you do, are there any final messages you'd like to give to the conference?
Only the two things of thanking you very much for your contribution so far, but you can take a breath maybe over the summer, but my warning is that this isn't going away anytime soon. And I fear, as most of us do, that it's coming back, and it's probably coming back in the winter with an overlaid flu season, central heating in houses, indoor groups, everything the virus loves. And I fear that your work is not done. So you might want to take a little self-catering holiday if you wish for a few days, but don't go too far.
Can we come to Scotland yet?
You can, as long as you don't bring the virus.
Thank you so much for that. That's been hugely.
You're welcome. Thanks for having me.
No, you're very welcome. Right, well, that was an excellent presentation there. I'm now very pleased to be able to introduce our next two guests, Shaheen Bhatia and Andrew Lane. First, looking at Shaheen. Shaheen is an award-winning pharmacist, having won the Entrepreneurship Award at the Pharmacy Business Awards. And Shaheen's pharmacy is not a million miles from my constituency, so I'm especially pleased to hear from her. So over to you, Shaheen. Could you tell us what it's been like in your pharmacy during this crisis?
Hello there. Thank you for inviting me here. I've been a community pharmacist for 35 years now, but in the last 4 months, I think I've seen probably the most intense, stressful times that I've ever experienced. But at the same time, I've also seen some of the most uplifting stuff that I could ever imagine. I think I've learned more in this short period than maybe I have done in the last 10 years. We did deal with a lot of sort of panic-stricken public, but at the same time, you know, our first priority was how to reassure the staff, because we had abusive customers at the door, trying to access paracetamol because it became like gold dust. So we had to obviously try to protect ourselves, try to source highly inflated PPE, which wasn't provided. we were sent these perspex screens through our pharmacy groups, etc., which were terribly hopeless because they fell down in days, and then had to ask, say, even hubby to use his DIY skills to make them more fit for purpose. And then there was a variety of services that we realised that we could not do because of the we needed to avoid close contact, and of course, you know, and prepare for the risk. But there were some services, obviously, that, you know, we had no choice except to continue, and which was going to involve very close contact. One of these was my Bovidal pilot. So last year, my pharmacy and I piloted the first NHS UK pilot for the administration of the buprenorphine depot injection for opioid substitution treatment. We was very pleased, as I said, to be initiating such a pilot. And in my borough, there was only my locum and I who could actually provide it. So as a result, there was no way that we could actually halt the service, so we needed to continue. So we had to come up with instant SOPs on how to give the injection, come up with, you know, ways that, you know, how we're going to protect ourselves as well as the client by giving out masks and putting on full PPE. But we created those SOPs, and now we continue to do that, and actually got through it quite successfully. So where the PSNC is only just now giving out the guidance for preparing pharmacies for the flu vaccination, as Matt Hancock said is going to probably be on a large scale, I'm actually quite glad to say that we're well prepared for it in our pharmacy. It was interesting, as I said, with Jason's talk, I did mention that I had been contacted by the lead pharmacist there for the substance misuse from the Grampian Trust, who are actually also interested in looking at the pilot that we have done here, and they're actually looking to start their own. So I'm really pleased about that, because one of the things that I think has come through this, and I noticed in my own local areas, that many pharmacies actually were working together, not only in sharing stock, in sharing experience, in helping each other, in trying to reduce each other's anxiety. And the fantastic thing was that we all put our patients above profit and competition, and maybe this is going to be the best new way to work. So I certainly think it's going to be a good start for everyone. Now, the other service, obviously, that we couldn't refuse was for EHC supply. It seemed to me that, you know, there was lots of young people coming in. They were telling me how they've been turned away from lots of other pharmacies because of the fact that no close-up consultations were allowed. But when I looked at these people, and obviously on the point of refusing, it seemed morally wrong to turn them away when they so desperately needed the service. So again, we had to come up with our own instant solutions and protocols on how we were going to do this, whether they filled out questionnaires in the main part of the pharmacy, if they were happy with consenting that it wasn't going to be completely private, or keeping the doors open, having the pharmacists again covered in, you know, protecting themselves with PPE as well as the client, and obviously also asking them to maybe phone in advance if they can for next time. And just as Jason mentioned earlier, I actually brought this problem up with our local public health, and was discussing how if gum clinics or sexual health clinics and contraception clinics generally had either reduced hours or were closed altogether, where were these people meant to go? And it actually led up to the problem of discussing the massive increase in sexually abused people through domestic violence or otherwise, which we've seen through the COVID period. So as we was discussing, we said, well, why don't we come up with a solution, since pharmacies are open and more accessible, and we're already now supplying EHC, we've come up with a solution on how to do it. You know, can we not then perhaps help these people out? So as a result, we've actually starting to pilot a service for sexually abused people and offering them a safe haven. It will be for all ages, and they will be able to access EHC as well as STI testing, as well as we will be able to signpost them to the right area to get some help and advice and perhaps protection. One of the other areas that we noticed that people were starting to come demanding blood pressure testing, because where they were meant to get reviews from the GPs, and obviously the GPs not having face-to-face consultations, at least not in person, were just told people to come and get blood pressure testing from pharmacies. I did think at the time it was a little bit unfair that because pharmacies hadn't been told about this in advance, but I actually thought, then why should we ignore this? Maybe this is a service that needs to be actually picked up. So we've decided to do a private service on blood pressure testing. Again, making up protocols that safeguards both the patient and the pharmacist. And even in the last 2 months, we can actually say we've saved at least 3 lives of people who had extremely high blood pressure, had to be instantly referred. I've had one patient come back with thank you cards and chocolate, saying if the service wasn't there, she was certain that she could not have been saved. So perhaps this is a service that could continue, but what we do need is we need structured pathways, we need integration with the GP contract for these kind of services. So perhaps again, as this COVID situation is going to continue, maybe it's another service that we could be picked up and maybe linked into the AF service that was going to be continued before we started the COVID season. Now, my highlight of the COVID season so far actually was when I got quite excited that there was a big group of people starting to gather at the door, and I thought to myself, oh, it's going to be really busy. And then I saw that the reason was that Ross Kemp had been invited to our farm because I was asked to take part in a documentary that he was doing with living with addiction to painkiller medication. This is about the misuse of over-the-counter and prescription medicines which are opiate-based. It is a very serious problem. I know that with opiate use that we are now on a cliff edge of an epidemic, and it certainly needed to be highlighted. The documentary was extremely well done. Unfortunately, because of the length of the documentary was short, while they highlighted the problems, we weren't able to actually discuss the solutions to those problems, and solutions such as that there are pharmacies, who are supplying naloxone injections, which is an opiate blocker, to people, who are using heroin or methadone, in fact, as well as that there are programs to address these issues. And I know the further training needs to be done with pharmacy teams on this. There is a very good CPP learning program called Addiction, Misuse and Dependency, which I will recommend to everyone. I think that where remote consultations has just been mentioned, I think one of the biggest problems that's come through this is that we've increased our deliveries by 80% perhaps. So we've reduced contact time with the pharmacist. So we need to make up for that loss of contact time and intervention. And again, it's another area where we should pick up about remote consultations so that we can offer services similar to perhaps to MURs, or should opiates actually be added to the new medicine service? Because it's obviously a massive area of concern. So that needs to be looked at. I have, as I said, was very pleased with the documentary because I got a lot of feedback from that. But I will finish with saying that throughout all of this, again, my total and utter admiration for all the health professionals who've been involved throughout the COVID epidemic so far and how they've dealt with it. But my real respect also goes to all my fellow pharmacists and our staff who've just worked so amazingly throughout it, taken the challenge with gusto, coming up with innovative ideas on how to get around the problems. All we need now is just to get the right people to fight for our profession, to get the respect and that we deserve, and to be paid accordingly. But I'm looking ahead at our profession with a lot of pride and positivity.
Thank you, Shaheen. And can I just say, a presentation fizzing with innovation, which is fantastic to hear. And I think you probably speak for a lot of people when you say that, you know, this has been both the most uplifting and the most challenging period for everyone involved in pharmacy. I'm just going to hand over to Andrew Lane, and then we'll have some questions at the end to the two of you, if that's okay. I'd just like to introduce now then Andrew, who's probably known to most of you as chairman of the NPA. He's been in this role since earlier this year, having been on the board for a very long time, and is a pharmacist as director of Alchem Pharma, operating 14 community pharmacies. So, Andrew, the floor is yours.
Thank you, Jackie. So I think you posed the question right at the beginning. So what did we learn about community pharmacy during the COVID-19 pandemic? I think the one thing that stuck out for me was at the height of the crisis, only pharmacies and food stores kept their doors open. It was really noticeable. The pandemic, I think, has reminded everybody that the supply of medicines is one of the most important activities for keeping the NHS functioning and the country healthy. Whilst many GPs, of course, went to remote working, we stayed face-to-face. And I think for me, that is the one thing that resonates. And I think I actually met the Secretary of State in a pharmacy in London a couple of weeks ago. And I think that's something that resonated with him, that actually the public really liked the fact that we were there face to face. And I think whilst they're there, I think the public are more accepting of digital services generally, but they continued to use their local community pharmacy during the crisis. We actually commissioned a public opinion survey during the crisis, and the findings were very revealing. And to that particular point, 62% of people visited a pharmacy during lockdown. And whilst that number, using the internet has obviously clearly been out there, it's increased, the total numbers getting their medicines this way is still quite small. It's maybe about 1%. And the polling that we carried out early in June found that 77% think that it's important to have the face-to-face access with a pharmacist. And that was compared with just 5% who don't think it's important. So again, if one thing has come out of this, I think the Secretary of State has also recognised that we have demonstrated that we were there for the public in a face-to-face capacity. And interestingly, in that same survey, only 11% wanted mass automation and centralised dispensing. And that actually compared with 74% that wanted locally based pharmacies operating as neighbourhood health and wellbeing centres, providing that face-to-face advice and consultations. So I think the COVID pandemic has highlighted the opportunity to bring that face-to-face and technology together. So bringing people together, not forcing them apart. Interestingly, we've had some success in some of the NPA's own technology. We launched a delivery app called Pro Delivery Manager. That actually supported delivery services to the shielded and vulnerable population during the crisis, which again is another example of how we already use technology to enhance rather than replace the local face-to-face service. Interestingly, listening to Jason, and he mentioned the NHS Near Me service. Well, obviously, Scottish community pharmacies being able to access that system, used extensively across primary care as a tool to visually connect with patients, as you heard from Jason. Based on the Australian Attend Anywhere system, interestingly, and developed obviously in Scotland, in the Highlands. And, I think that's something that, is it Claire Morrison, I think Jason mentioned, should be very proud of being a pharmacist, having brought that into Scotland. And I think if there's one thing we can do, let's see how we can scale that. That's got to be a quick win for England, for Wales, for Northern Ireland, for the other countries. You know, let's not lose that moment. I think again, you know, you can pick things up on the calls. That was actually going to be in my presentation, but to have Jason talk about it there, and we didn't prompt Jason to bring that up, interestingly, it's clearly been a way of connecting people. So community pharmacists are actually a committed bunch. I think that Shaheen has testified to that. They dealt with a huge upturn in work in the early stages of the crisis. And can you believe they opened for an additional, this is an additional 100,000 hours. They were courageous. They had more direct patient contact than any other health profession, and arguably any other public service, at a time when the risk of catching COVID was at its peak. So at that time and now, they continue to care. There are so many stories of going the extra mile. And again, we've heard Shaheen give examples in our own locality of that, to support sick and frightened patients. And in Shaheen's case, the vulnerable, the people who've been sexually abused, and we've obviously used pharmacy as a way of having a safe space for those people. But we did have problems. The medicine supply chain, it's resilient to a point, but shortages are an ever-present concern that community pharmacists have to deal with on a daily basis. We spend more time than anything on the phone trying to source medicines. And during the peak of the crisis, there were particular problems with a number of inhalers. You might have recalled in the press, that was being talked about early on. Community pharmacists' role in dealing with medicine shortages and minimizing the impact on patients is often unseen and an undervalued part of their role, but nevertheless, it's absolutely vital, particularly in that case to all the asthmatics. So I'm really proud of what independent community pharmacy did to play a major role in response to the crisis. I'm also proud of the NPA for supporting our members, generating hundreds of new resources, the FAQs to help our members respond to new challenges on the front line, and working with the media and our contacts in government to ensure that their efforts don't go unnoticed. The sector is capable of innovating, as we've already seen, and we need to be prepared for the new world post-COVID. They're not going back to the way they were. And I think, was it Jason who just said, this isn't going away anytime soon? You know, and I think he's absolutely spot on. I said to him before we came on air, he's the person I most admire on any of the news programs of telling it exactly how it is. So you know, it's great to have had him here. But finally, turning back to some of the Secretary of State's words here on this platform yesterday, and I quote, he said, "The opportunities are huge. 20 million GP appointments could be referred to community pharmacies every year. And there is much, much more that you can do. So I look forward to the continued rollout of more and more clinical services with the goal that all pharmacies should be operating at the top of their qualifications, at the top of their license, engaged with and supporting the communities who we serve to get the very best possible treatment as close to home as possible." Now, obviously, they're very encouraging words, and I think it fits really well with the stuff Jason said earlier, and evidenced by what Shaheen is facing on the ground. But those are encouraging words from the Secretary of State. But we must recognise that to achieve all of this, our members need a sustainable funding system that will reward excellence and innovation, whilst at the same time keeping the valuable supply function maintained as we did during the peak of the crisis. We also need to ensure the costs that they've incurred are repaid so we don't lose that valuable resource. So to end, we're ambitious for change, but it must be sustainable and rewarding for our members. Thanks, Jackie.
Well, thank you, Andrew. And clearly, when you escorted the Secretary of State around pharmacy, your message landed because he's playing exactly the messages back. But I'd also like to thank you and the NPA for keeping me informed during the crisis as well, and keeping me abreast of the challenges that have been faced by the sector. And I'm very, very thankful to all of you for stepping up to the plate. Turning now then to questions, and perhaps I'll put this question first actually to you, Andrew. It's from Tariq Mahmood, who's asking, do we know how many pharmacy staff contracted COVID and how many deaths there have been, and how that compares with the rest of the health sector?
I don't believe we've collated that data. I am aware that I think there were sadly 8 deaths within the pharmacy sector that I'm aware of, but I don't believe in proportion to the rest of the health service that we've done that calculation.
Yeah, I think it just brings home that everyone involved at the coalface delivering health treatment was at more risk, and that's something we need to obviously make sure everyone remembers. Shaheen, if I could bring you to join the panel as well, and perhaps put this question to you first before going back to Andrew. Obviously, one of the questions I put to Jason earlier was how we can make the community pharmacy sector better understood by decision makers and politicians and leaders. And I was struck when you were giving your presentation, the whole thing you said about domestic violence and sexual violence services, where you've innovated this new service to people who are especially vulnerable. You'd also talked about, having taking readings of blood pressure, which again is such a common thing that people need to have done. So how do we make people like me and the people in government really wake up to the fact that so many things more could be done by pharmacy, and if we could get so much more value for money if we redirected some of the resource to pharmacy and away from other aspects of the NHS?
Well, my principle has always been, as Jason mentioned, that you run towards finding solutions. So because as patients come in, I think it's about demand. What are they asking for? With the blood pressure thing, obviously, that we had many people coming in, obviously saying that their GPs were requesting a blood pressure measurement, so they could actually maybe do a review on the phone or whatever. But the GPs were not necessarily thinking like, are these people going to be doing it themselves, or is someone else going to do them? But we even had requests, as I said, GP just said, go to your pharmacist, without really sort of thinking, are we actually practically capable of doing that? And what's the other thing that comes through this was that people can't assume that just because people can buy blood pressure machines from everywhere, that they're going to do those measurements correctly as well. And it might not be necessarily, again, will the doctors take those seriously, because they know that obviously the way that they use them is not going to be, as I said, correct. So as I said, we also spoke about technology, and I know that there's ways of, some people can handle technology, but then you've got the older people. I've even had one woman where I again was trying to refer her back to the GP, because she also had very high blood pressure that she had tested here, and she was told to book her appointment online, and she goes, well, I don't even have an online account, how do I do this? So we become the middle person, but we are there actually to take this evidence down, and I think we need to then approach the right people. In my area, I think because of the fact that I've been running pilots since 1996, I have got a really good relationship with my public health, as I said, and other local professionals in the area. So I think it's about making sure that those conversations happen. So the same with, as I said, that's what happened with the sexual health side. It was discussing it with public health and saying, taking a kind of solution, look, that we've got a problem here. So how do we, as I said, take this forward? It needs to be addressed. So I think even for them, they're obviously, they're not pharmacies. They're trusting the fact that we're seeing things on the ground. So I think it's important that we pick up that evidence and then try and present it to the person that we can do, that was hopefully someone well, maybe a local MP, and we'd love to have, an MP like you in our area would be fantastic. Anywhere, as I said, we said, can we take this further? I think we need that initiative, but we need the passion to drive them forward.
That's great. What I would say in response to your last point, Shaheen, is actually, I speak to lots of MPs, and without exception, MPs have nothing but positive things to say about their pharmacies. But actually, I would encourage everyone on this call to make direct contact with their MPs and invite them in and show them what you do. Because there's nothing more powerful than actually seeing at first hand and hearing, I know a lot about pharmacy, but every conversation I have, I learn so much more about what you do. So, part of that, running towards the limelight and not being backwards at coming forward, I think, those of you on this call, please share what you've got to tell, all your good stories with your members of parliament, because we always like to hear good news and see what we can do to help. But if I could perhaps turn to you again, Andrew. I mean, what Shaheen's just talked about there is, it's almost like, the NHS says, oh, you'll go see your pharmacy in the first instance, but doesn't actually properly appreciate the value of what those consultations can bring in terms of intelligence and in terms of record keeping. And it's almost like it's an accessory to the NHS, but not an integral part of it. So, I mean, what would you say about that?
Yeah, it's interesting, Jackie. I think having listened, I think last week, you might be aware that in our sector, Professor David Wright has done a review. That's just how the internals of our profession are working at the moment. And one thing I think he observed, and I think and you can build on this, is the NHS suffered, and we suffer perhaps more than anybody, from pilotitis. He coined that word. The NHS is full of pilots.
Yes.
And actually, when you get something good, why can't it be just scaled? And, here we've just heard the National Clinical Director for the Scottish Government talk about a video conferencing system that's not only just video conferencing, it's a platform that is shared across all the different parts of the health system. And, why would you have another pilot in England for another system? Why wouldn't you just scale that across the whole of the health service? And wouldn't it be much easier that we just got on and did that, rather than pontificating and wasting time and effort when we know it works? And I just think, that would resolve an awful lot of what you've just described, of not having the right data in the right place, having good conversations. I speak to my local GPs on Zoom every other week. And we've just become used to it now. This is just going to be a normal way of working for everybody. But I think, to your point, I think let's not suffer from pilotitis. Let's find stuff that works and just crack on with it. Because Shaheen's a classic example. Here's some really good exemplar practice. Let's just scale it. It's valuable to patients and the NHS. And that for me is what we should be doing.
Oh, amen to that. But culturally, I think government is so bad at this. It's like, if it's not invented here, it's not good enough. And we don't do enough to share best practice. I mean, one of the things, I think we talk the talk often, but we don't often walk the walk. And perhaps that's where we can all do better as well. I've also had a question, it's in the same vein, from Graham Phillips, who asks, why is the community pharmacy sector valued more in Scotland than in England? So do you want to have a go at that one first, Andrew?
Well, I know Graham extremely well. And I would echo that question is very relevant. And I can pick up on just what I was saying there. But I think I'd go back to Jason's summary, I think, of why it works in Scotland. Didn't he say that he shares an office space across the corridor with Rosemary Parr, who was the Chief Pharmaceutical Officer? Now, I know Rosemary, and I've known her for a lot of years, and she's always said to me, the value of pharmacy is in the social capital that you provide to the public. And those words, I think Andrew Evans in Wales also echoed that same sentiment. The social capital is the valuable bit of what we do. So, you know, I think it's important that if there's any opportunity, perhaps for England to shine, then to Graham Phillips's point, our Chief Pharmaceutical Officer probably, you know, needs to talk more about the things that Jason is doing in Scotland, and just go and learn from what we're doing elsewhere. And you know, we've got that opportunity. Let's make it happen.
See, it always felt to me when I was a minister that Scotland actually had the optimal sized health economy, and that in England we were too large, and therefore it became too fractured. But I mean, it's one of those things, isn't it? It all comes down to leadership at the end. And if you've got the right values at the top of the NHS and the right, you know, and the steer from the Secretary of State, and that working positively, then, you know, it shouldn't matter about size, but it does come down to personalities in the end. I just wondered, so Shaheen, we're getting lots of comments about what a brilliant ambassador you are for the sector. So I think you can pat yourself on the back for that. But I just wondered, I mean, in terms of, you know, as Andrew's just said, we have too much pilotitis and not enough sharing of what works. I mean, has there been any? I mean, you've effectively talked about your domestic violence and sexual violence services that you brought in with discussions with your local public health, because this is something that you could respond to. But has anybody else shown any interest in that at all?
Well, this is, as I said, with public health, we're in fact about to start the pilot next week. So it's early days yet, and I think they want to obviously see if it's going to work out, and hopefully I can't see why it wouldn't, because, you know, we do most of the work already, except that it'll be a different clientele, a different group of clients anyway. But the thing to do would be then that if it proves, shows us great evidence, then that can be rolled out. Obviously, I think even sometimes people like public health and so on, they sort of worry about rolling out a service instantly to everywhere, because they don't know what hiccups there would be, and that is understandable. So I think, as I said, that's at an early stage. But other things, like as I already said, something really basic like blood pressure testing, like as I said, we do have like NHS health testing in the past. We've got things like that, but, you know, because of the worry about blood testing in general, we're not doing that. But something as basic as that, so if it was linked into AF, what my thing is that it can be taken straight away and linked, and we want some, you know, structured pathways about how to share that information with GPs, and so they were not just relying on the patient, or you can now take this measurement back. And then it's also showing the fact that we did that work and we shared it with the GPs. Now, those are the kind of things that I would definitely like to see upscaled immediately. I can't see why there should be a hold up on such things. And I'm in the process of speaking to my GPs about doing it locally, and maybe they will take it to the CCG. But unfortunately, those things are just so slow. So it would be great to see people like the NPA or MPs like yourself to make that happen, because, you know, we've already been told the COVID season is definitely not gone. It's going to go on for some time. And when I get some of the sort of slightly older people, as I said, who do not use, you know, Android phones or things like that, and say, well, how do I communicate with my GP? They're really, some of them are really dumbfounded about it, and there's so much anxiety because of the fact that they feel they can't see their GP anymore. I know we keep talking about remote consultations, which is fine, but I think we've still got to remember that there's going to be a certain group of people who still may not be using those that well. But we're seeing the average person walking in through the door, and as I said, not everyone has those facilities or are comfortable with using those facilities. I think nearly every day I must have at least 30 conversations actually with people were saying how they can make a telephone call to their GPs and are saying they'll be able to request a call back, and that if they had a mobile, they'd be able to see you. But we actually have to explain it. I'm doing more advertising for the GP than sometimes I'm doing for myself. And this is just to make sure that patients get best care. That's all we want at the end. And we need to be integral in the pathways with the GPs. The GP contract needs to be changed where it is merged with ours a bit more.
Yes, it's interesting, isn't it? The public view the NHS as this one monolith that does everything for them. The truth of the matter is, it's lots of disparate parts that are very poor at sharing information. And in many ways, the pharmacy is probably the best place to help people navigate where they need to go. And it's interesting. Those are conversations. You talked about your local conversation with your GPs and your CCG and public health. But really, if we are going to get best practice, this is something really, Andrew, isn't it, that the NPA needs to show leadership with, and working through conversations with national government and NHS England to attack some of these issues. I mean, what sort of plans have we got going forward to do that?
Well, I think you are right, Jackie. Through the continued advocacy that the NPA is now promoting, and the fact that we have developed relationships probably that we didn't have a year ago, I think it's incumbent on us now to be the conduit for that best practice, start sharing that best practice better. A bit like Jason said earlier on, get out there, step up into the limelight and demonstrate what can be achieved. And I think it's incumbent on us to do that. What did he say? I wrote it down. No one's going to do that for you, he said. People won't come looking. So seek the opportunity to engage. And I think that is absolutely what we've started to do, quite frankly, and will continue to do. Because I think, we've been just sat there doing the day job now. I mean, when I qualified, I'm not going to tell you how many years ago, but it's a long time ago. Pharmacy hasn't really been able to push itself into the limelight. And I think we've got an opportunity, albeit a sad one with the pandemic because so many people have died, that we now use the fact that actually the public realise a lot of them what we've done for them in the past few months. And we build on that. We build on not just the public perception of what we do, but actually we bring that to your point, Jackie, to the people who will want to be voted in next time, for want of a better word. For the MPs out there who, I know you just described it, who would probably not walked into a pharmacy ever. And it's incumbent on a lot of our local members to forge relationships with the local MPs and make sure that the MPs are aware of what we do. And I think, you probably admit yourself, your eyes have been opened a little bit more to what we do since you've become more involved in what we do. And I think we've got to just demonstrate we can, to Shaheen's good practice there, scale this across the country.
Yeah, we only know what we know. That's the brutal truth of the matter. And there are pharmacies offering services that most MPs won't have a clue that they do. I mean, they will only have their own experience. Quite often, we are people who work, in a number of locations. If we have repeat prescriptions, we just have them done, and that's the end of it. So I would definitely encourage it there, because I mean, to be frank, we always like to, as I say, we like to see good news, and you've got nothing to tell us but good news, and we want to celebrate exactly what you do for us. I don't know, Shaheen, I mean, what would you like to see from the NPA in terms of engaging with this stuff? If there's any really big ticket items that you think we could make a real difference with, if we put to the top of our list with dialogue with the NHS and the Department of Health? Well,
as I said, I've already mentioned, I have had good help from NPA, I must point out, actually, because especially things like when we were starting the Bubidal pilot, because depot injections were never actually administered by pharmacists in the past. And then this is why, as I say, the Grampian Trust, in fact, contacted me that they were using Bubidal, which is, as I said, is an injection for opioid substitute treatment, but they were only doing within the drug and alcohol clinics rather than passing it out into the pharmacies. So, because they've looked at our model in Redbridge, where, as I said, is pharmacy based, they're also trying to now take that out. So people like NPA, where I have my liability insurance with them, I was actually able to go through something which was no service has been done before. So obviously it was good that I had to talk through the risks and how I would get myself covered and so on. So they're very useful. So if you are looking at sort of any services that you feel that, okay, you're not sure that the risk is high, so the NPA, again, as I said, is fantastic in trying to weigh it up, and I don't think that they don't dampen your enthusiasm, but actually sort of help you to work out the best practice there. But in other things, as I said, like I've already mentioned that, a couple of things like, we even said with the Ross Kemp documentary, in fact, we're talking about how do we bring it out into the limelight. Programs like that, as I said, because those people have got so many followers, they certainly, again, highlight the work that pharmacists do anyway. So we need to maybe build on things like that the NPA can use, that platform as well. Say, well, this is how we can help. So, our MURs, unfortunately, are going to end in next March. But can we replace them with other services? Can we build on the new medicine service, especially for a serious group of medicines like the opiates? That's where the NPA can help, as I said, to build on services, as well as maybe creating templates for pharmacies saying, well, tell us what services that you are offering or you wish to offer. And again, they can take these to the, for discussions around the table. My frustration is that I have done hopefully successful pilots here, which has led on to some good work. But it's the ones, as you say, as I said, you've got evidence, but they're still not being taken further. You haven't got enough people looking at them, or the CCGs don't take them seriously. So that's where, as I said, the frustration for the independents or the person on the ground is I think felt the most.
Yeah, I think I'd agree with that. I don't think NHS England does nearly enough to capture good practice on the ground, and it's very, very siloed. But we are looking at how we do things in future. I think this is probably one of the lessons learned since the last set of reforms. So we don't really want anything too bureaucratic. I just coming back to one of the things that the Secretary of State said yesterday, where he said that he was looking forward to pharmacy really being at the coalface in terms of rolling out a huge flu vaccine program this winter. And certainly, as we know to expect that this virus is going to be with us for some time. As I think that one of my ministerial colleagues said to me this morning, that the virus is in decline but not gone, and I don't think it's not going to go. And one of the messages we've been getting from the health establishment is that flu vaccines will help as we approach winter, when it's going to be possibly the risk of a second wave. But in that sense, that's obviously going to encourage a lot more people to want flu vaccines, and the pharmacy sector, as you've heard from Secretary of State, is seen as part of the delivery of that. Would you say you need additional support, or what support would you need to deliver that? If I could ask you perhaps first, Shaheen, before going to Andrew.
I think definitely would be to more provision of PPE, because there's no doubt, as I said, with vaccination, it's that we would have to change PPE each time we do a patient, because that's what it's going to require. I mean, I know even again in my pharmacy, I've spent so much on PPE because, as I said, my staff came first. But I know that the value of putting my staff first was the return I got from my staff, where when asked that, I realized, we, in fact, again, we did the, we've got the ethnic minority staff working here as well. We did risks right from day one. So, we didn't wait for anything to come through, but protecting my staff and spending the money on the PPE from day one, I realised I also got their total dedication. They've stuck it out for all of these months and not even asked for a day off, which is just, as I said, without having those kind of assets, you can't make a team work and providing what we have. So that, as I said, would be one of the first priorities, as well as obviously make sure that the guidance is really clear about what we can do. I mean, luckily I've already had to do it because I've do the injections already, so I don't fear that, because as I said, it's not going to be a problem. The only problems would be how you want to manage big numbers. What will be interesting this year actually is you may know from in previous years, it's almost been very, very competitive with GPs for doing flu vaccinations. I don't think that would exist this year. So will be, as I said, again, interesting for all round on how we manage the numbers, because there were quite big numbers that GPs used to do. They won't be able to necessarily do all of those large numbers. So we will have to be able to cope with those numbers. And so we'll have to come up, as I say, again, with some kind of innovative ideas on how we want to do those big numbers. Maybe would we want to perhaps, rent, like say, town hall places, which might be ideal, or community halls, maybe not just in the pharmacy. So we're going to need people like the NPA again to perhaps advise us how we might be able to do it in those kind of community settings, which may be a little bit easier than even doing it in the pharmacy. It's just, as I said, one idea. I even sort of came up with a thing like, they're doing with the COVID testing, like, can we have tents out on the pavement? So that we might be able to, so, like you have a walk in and walk out, with 2 doors. Another way, because then you're keeping those people completely separate from the pharmacy itself. There could be a lot of different ways that we address that. But again, as I said, it'd be nice if NPA as well, or obviously groups like that come and let us know about some kind of templates that they want to advise us. We just make sure that, we tick all the protocols.
Thank you. So Andrew, I mean, it's another example of expectations being laid on the sector, but the support's got to follow behind it, and Shaheen's just highlighted PPE. I mean, did you feel that the pharmacy sector was at the back of the queue when it came to getting PPE earlier on in the crisis?
Yes, I think you probably remember that one of the things I was first vocal about in this pandemic was the fact that our members were out there on the front line without PPE, and everywhere else had locked their doors. And I think, we've seen it in other countries. I think I mentioned South Korea at the time, where everybody had PPE. The public were encouraged to wear it. They locked down early. Absolutely. But to the point that you were just making about the flu, I don't know if you saw the headline in the Times this morning. Cold winter and bad flu could leave 120,000 dead from the flu. And I think, picking up what Jason said as well, again, it's not going to go away. And pharmacy has a massive, massive role to play. But again, to Shaheen's point, it needs to be coordinated. It needs to be coordinated with the GPs, because we can't afford to have the battles that we've seen in the past between these are my patients, these are your patients, and to the point where in Gloucestershire just last week, the week before, we had the LMC, the local medical committee GPs on who I speak to on Zoom fairly frequently, and we've got a joint statement that's going out to pharmacists and to GPs, but there isn't any thinking locally how the innovation might work. So one GP said, well, we'll just have a drive-through. People will just come in, to Shaheen's point, in a tent, stick their arm out the window, jab. Now, okay, that's one GP's thoughts, but you know what? It's going to need a proper coordinated response, properly planned, properly funded, to make sure that we don't get 120,000 people dead. And I think that that's something that we've got to work on. So and you know what, we're up against the rock and the hard place now, aren't we, with the beginning of flu planning. That they're starting to have the discussions, already having the discussions, in fact, at a local level, and we've got to be embedded in those plans, but they have to be fairly radical on the basis that, to Shaheen's point, if we're going to be involved in flu this year, the GPs and the pharmacists need proper protection, because the last thing we need is the medical profession who are giving the vaccination to be going down like dominoes when the crisis pops back up again with a winter spike, if indeed that does happen, and we hope it won't. But we need to be prepared for that. So yeah, PPE, to your point, absolutely vital. We were missed off the list, and we've got to be recognised to be top of that list if we are involved in this flu planning properly.
And I mean, just as another question, I mean, who is best placed to coordinate that? I mean, as you say, if it's going to be done efficiently and effectively, it means GPs and pharmacists coming together and with properly allocated plans as to who delivers what to whom. Now, who is best placed to deliver that? Because certainly one of the things that I've thought about this crisis is that local directors of public health were underutilised, and there was rather too much done through the top-down structure of the NHS, which obviously then, if it comes to CCGs, then the GPs are going to have, you know, the dominant voice. But I just wondered if you had any perspectives on that.
I think you've got to look at this. It's a national crisis looming. We have to have a national solution for it. And there's a bit of a prescription that's got to follow. So if we have a plan, we stick to it. And the GPs understand what they're doing. The pharmacists understand what they're doing. We're all protected adequately, and we get on with it. And I think whatever we do, we've got to have that plan fairly quickly, because the local discussions, as I've just described, are absolutely happening now. And we can't just invent it locally. We can't be going into a potential flu crisis on top of a pandemic with local pilotitis, for want of a better word, if that makes sense.
So command and control with clarity and certainty.
Correct.
And resource.
Absolutely.
Yeah.
Coming from both NHS England joined up strategic thinking, Public Health England joined up strategic thinking, supported by localities at CCG level, so they understand what's required. Otherwise, it'll be left to, as I've just witnessed in the last few weeks, back to the same old, GPs being unsure about what they're doing, pharmacists unsure about what they're doing, and more importantly, the platform, which we could have to describe who is getting it, who's been tested, and that actually would link to any future COVID vaccination program where we've already seen test and trace fail in so many ways. We need to be ahead of the curve for that. And, you know, picking up what Jason said earlier, there's a platform that's already there. You know, it's not rocket science.
Yeah, well, it often is when it comes to these. But thank you to all our panelists for that. And we're coming towards the end of our session. I just wanted to wrap up by sharing some statistics which the NPA have launched just this weekend, and I think it got some good coverage. so well done to that. But it was an independent survey of the public, and it looked at their perceptions of pharmacy over the last 3 months, and it's actually very good news. So I just want to leave you with some statistics. In short, the public thinks that pharmacists have played a critical role during COVID-19, with 89% seeing their role during the crisis as essential. As many as 55% of people have visited pharmacy for medicines during lockdown. 55%. I mean, that's a pretty hefty contribution. And interestingly, 78% of people think we have about the right number of pharmacies. I suspect actually that the remainder think we should have more rather than less, but that's not a question that was asked. Going forward, the public would like to see pharmacies play a greater role in healthcare, with 78% valuing a face-to-face relationship with their pharmacist, 74% wanting pharmacies better integrated with other NHS services, 84% say the NHS should do more to make use of pharmacy skills, and finally, 71% think pharmacists should expand their offerings to take pressure off the NHS. So actually taken together, I think that's a pretty good manifesto, to be honest, and that is exactly the basis on which we should have future engagement with NHS England, with Public Health England, and with Department of Health and ministers. So I look forward to working with you to have exactly those conversations, and we must make sure absolutely that we learn from everything that's happening all over the UK, and particularly that the 4 nations share what works well for them. So on that note, can I thank you all for joining us today? Can I thank Shaheen, Jason and Andrew as our panellists for being very frank and provocative with their comments. And thank you very much for all of you for joining us. Thank you.
Thank you.
Thanks a lot.
Bye.